Hi, Dr. Rozell. Welcome to MD Newsline. For people who don't know you, can you please introduce yourself to our audience?
Hi, I'm Dr. Shaina Rozell. I'm a hematologist oncologist with Affiliated Oncology here in Chicago, Illinois.
So, there's a lot going on in the world of multiple myeloma these days, and there have been a lot of new development. I'm so curious, what new developments have caught your eye?
Yeah, it's been a insane and fun time in the world of multiple myeloma. Even being in a private practice, a lot of the questions is how do you actually keep up? And for some time, we learned all about triplet therapy, and so it was at the time the standard of care to use, for instance, Velcade, Revlimid, dexamethasone, and that was your standard of care. However, more recently, for the last several years, we have been learning more about the quadruplet therapies, and so I think it's been extremely exciting to look at daratumumab, and now isatuximab, and using these novel quadruplet therapies in treating our patients. We have had a wonderful sustained MRD with the use of these quadruplet therapies, and so I think it's exciting to see that these patients are doing well, they're living longer, and many of them have been able to avoid stem cell transplants.
Yeah. Can you explain MRD and how it plays a role in treatment?
Yeah, so MRD, or minimal residual disease, is pretty much a surrogate of seeing how well the bone marrow is without any evidence of disease. It has allowed us to see, it's been a surrogate for progression-free survival. It is a surrogate of a sustained response to the therapies. It has been a way to guide our treatments, and so I think it's the new marker. In terms of, for instance, progression free survival, overall survival.
So, when you're thinking about things like cell transplants, right? When do you consider autologous cell transplant in the era of advanced immunotherapies?
So that's a very loaded question. I think for years and years, the mainstay of treatment was the stem cell transplant. And so, you would give your patients treatment, and then the ultimate goal is that they would go to stem cell transplant. And so, what we learned is that many patients are not able to have stem cell transplant just based off of, age, other performance status. And so with those patients, they're not able to receive stem cell transplants. And so they did not have a great advantage as those that who actually could receive stem cell transplant. But that has changed with the advent of the quadruplet therapies as well as the bispecifics and CAR T. We've seen that patients have done extremely well, and again still had a sustained minimal residual disease, and similar to someone who actually had a stem cell transplant. And so I don't think it has been replaced, but I think it's still a adjunct. Um, and I think over time, we may not be performing stem cell transplants. I can think about the days we did stem cell transplants for breast cancer, and that's pretty much obsolete and not existent. We don't do that anymore. And so the hope is that, we may be able to stop doing or performing stem cell transplants in the future. Maybe, maybe not.
Mm. Um, so speaking of CAR T, how do you decide between CAR T cell therapy and bispecific, trispecific antibodies for relapsed or refractory disease?
So it depends. I think it all depends on where the patient is residing. Do they have access to CAR T tertiary centers? So when you think about CAR T therapies, those are pretty much only performed at tertiary centers. So here in Chicago, you have limited options is where you can actually have CAR T therapies performed. Bispecifics is a little bit different. Even in our private practice, we're doing bispecific treatment. And so, you think about, can the patient tolerate it? Do they have access? Number two, can they actually be hospitalized and receive the treatment and be monitored? You think about rural communities; they don't really have that access. They don't have the capabilities of being monitored or being able um, to have good transportation to go back and forth to these facilities. And so, and then you need to think about the capacity of the community specialists. Can they actually perform these newer, novel treatments?
And just kind of thinking about that and the presence of people in rural communities, for example, what are some of the workarounds or maybe areas of you know cooperation between institutions? What resources and options do people have when there are these better options, but they might not be resourced to implement them?
Yeah, so I think that is really having a bridge and being able to collaborate with these tertiary or academic facilities. For instance, my practice, we have a wonderful affiliation with Rush, where one of our practitioners, our oncologist, he goes out to Rush and he is right in the middle doing these stem cell transplants. And so it's been a phenomenal way to take care of the patients in the communities, still allow them to get access to some of the best care at some of the tertiary facilities, but still be able to come back home where they feel comfortable and feel that they got the best care.
Mm. So, when it comes to bone protection, how are advances in bone protection, infection prevention, and managing toxicities improving patient outcomes?
So those, changing and having a good bundle as far as infection, supportive management, I think is the mainstay. We've seen that, many of the life debilitating um, events with multiple myeloma is not just the disease itself. It is the in organ damage. It is the kidney failure. It is the bone metastases, the lytic lesions that could ultimately lead to someone developing paralysis. And so having your bisphosphonates, your Xgeva, your Zometas available, one has helped and shown to prevent some of these life sustaining events, but it also has been shown to treat the disease itself. Having a infection bundle has been great not only in the stem cell transplant era, but also when we think about all of these novel treatments such as the daratumumab, the bortezomib. They have side effects or increased infections in itself. You have your herpes zosters and things like that. So you definitely have to make sure you have something to protect the patients.
And then just thinking about just this increased risk of infection and just immunocompromisation, I'm sure that people have tons of comorbidities at times, especially, at a certain age, right? What are some comorbidities that you see most often? And I'm wondering how some of those treatments might overlap or interact with the treatment regimen that you would recommend.
Yeah, and I think that's the reason why we decide or how we decide to use one quadruplet versus another quadruplet or one treatment versus the other. We look at the patient, their age, their comorbidities. And so when you think about, the average population of patients being diagnosed with multiple myeloma, 60 and older, and we look at all the medical comorbidities that are affecting, the 60 and older population, it's not just the cancers, it's the obesity, it's the heart failure, it's the diabetes. You have to decide on which regimen you're going to use as you're taking care of these patients. Um, so, you know, in communities, people were using these triplet multiple myeloma regimens. But even back in the day, in my training, we used to use doublets. It was just your standard, Velcade dexamethasone for those patients who had really poor performance status. And so now things are changing where mostly all patients should be getting a quadruplet therapy because we have seen such a sustained response. What is different, I would say, is that those patients who are younger, more robust, those 60-year-olds, based off of the advanced trial, for instance, where we're looking at DARA and KRD, those are the patients that I'm probably going to give that, to versus giving them DARA, Velcade, Revlimid, dexamethasone. Those patients who are a little bit more fit, who don't have as much heart failure or those medical comorbidities, I'm leaning to using that as a quadruplet therapy.
Mm. And then, in your experience, how do things like home administered treatments and telemedicine, for example, change the quality of life for myeloma patients or even the effectiveness of treatment?
So what I would say is that home administration, we're not doing too much of that as of yet. What I can say is what changed things or a game changer for me is when daratumumab became a subcutaneous injection versus IV administration. And so we are seeing, less toxicity. We're seeing ease to administration, less time in the chair. I think it's making patients' life a little bit more easier. And so I could see in 20, 30 years from now that there'll be more treatments that may be administered at home, where you're not really worrying about all the side effects. I think sometimes, even with the bispecifics or in the CAR T, at this present moment, there is no way to administer that at home. These are the things that the patients have to be hospitalized, and making sure that they're not having all of these cytokine issues.
Hmm. And I'm wondering, just thinking about the specifics of how the disease progresses in each patient, how do genetics maybe play a role in disease progression and even reaction to treatment?
Yeah, so what we know is that cytogenetics, it plays a major role when you're not only looking at prognostics and you're having that discussion with your patient and saying, hey, you have a worse disease process than someone who does not have these abnormal cytogenetics, but also it tells you how they're going to respond to treatment. And so when we're looking at the data and having these discussions, I can say, hey, I'm going to give a patient, for instance, a quadruplet therapy, and they have these bad players. They have the 17p deletions, and things of that sort. And we see that these patients, although they still do well, they do not do as well as one who does not have these abnormalities. What we can say is that they don't have as much of a sustained or MRD, MRD that's sustained in comparison to someone who does not have the bad cytogenetics. So I think cytogenetics matters. I think it trumps everything. And so, when you're kind of making these decisions, that's how you are making a decision whether to do a quadruplet versus a triplet therapy. It's making the decision on whether to do a transplant. Does this patient have any high risk players where they need to actually go to transplant or not?
Mhm. Are there any factors that you say would make someone more likely to have kind of these bad cytogenetic related outcomes or progression? Is there anything that we're seeing just as far as trends of what may correlate?
No, I think, you know, we are learning more and more about the cytogenetics, but we can't necessarily say that, hey, why are you developing this mutation in comparison to someone else not developing this mutation? We're not seeing trends in like economic burden or societal norms that is making someone have, a bad player versus not. I think, the epigenetics, all of those things are still ongoing research is needed. And I think maybe over time we may see that.
Hmm. And then just as far as when you think about setting us up for research in the future as well, when we think about things like epigenetics, some of these unanswered questions about what makes people more likely to have these mutations, how do you see the participation or maybe lack thereof in certain populations in clinical trials playing a role in our ability to find these answers?
Ooh, I think that is a extremely important thing that, of course, we need to improve on. And I love to see that even the community practices are um, being more participatory in clinical trial research. As we know, for instance, minorities, are by far the lowest participants in clinical trial research, when the average percentage of patients enrolling is roughly about 2%. Okay. That is changing, where we're starting to see, for instance, even an advanced trial, I think there was about 10% of the patients who were minorities who were actually enrolled. And so I think, there's been a push to do more research in minority health, and especially when we see that some of these patients are the more affected, and so I think in the future, um, that is a big push, and I think that we'll see some improvement.
Hmm. I'm wondering, is speed to treatment and diagnosis, does that impact the likelihood of a mutation occurring in your opinion, or is it?
I don't think it affects the likelihood of a mutation occurring. The mutation has occurred. Um, I think what it affects is the likelihood of getting good treatment.
Mhm.
I think it affects the likelihood of avoiding some of these life-sustaining events, such as these catastrophic bone metastases, or needing to end up on dialysis unnecessarily. I think so. In that sense, time to access, time to affordable care, time to actually sit in the chair with a physician. Those are what's important.
And just on the topic of access, and when we're thinking about these kind of genetic factors, for instance, um, Is there a possibility that someone might not get the proper genetic workup? And if so, what would you suggest to patients just to make sure that they're having, their disease monitored in a way where they can catch these mutations? Because I imagine that not really understanding the genetics could become very expensive when it comes to going down like the rabbit hole of problem solving in oncology. So, what's your take on that, and what would you suggest for patients?
So when it comes to multiple myeloma, I think, looking at the cytogenetics, looking at MRD, I think that's extremely important. And so, um, always looking for second opinions. I think it is always great to make sure that your physician is well versed in the disease process. Um, Monitoring, I think it is standard of care that, all providers should be doing the minimal, the cytogenetics, looking at MRD. I think that is, um, at minimum, that should be performed. And so you want to make sure that, that's what your provider is doing so that you kind of know this is not just multiple myeloma. Is this a high risk multiple myeloma, or is this standard risk multiple myeloma, or is this low risk? Because those are treated differently, and we know that the survival is different. Um, are you being able to be considered for stem cell transplant? Are you being able to be considered for bispecifics or CAR T? Making sure that you have um, a lot of different options at your disposal that you could not get necessarily, for instance, if you live in a different community.
Mm. And I mean, you're saying a lot of different options and things like that that I feel like people might never have heard of or been aware of, especially, when they are in a moment of stress, in navigating their treatment. Do you know of any resources, or do any resources exist? Because when we talk about looking for second opinions, you kind of have to know what would be a valid second opinion, right? Or if a second opinion is even necessary. I'm just wondering from a patient perspective, where do people go to make sure that they are to what's kind of like the blue book, the standard to make sure that the care that you're receiving or the answers that you're getting are complete enough for you to make an informed decision? Do you have any thoughts on that?
That's hard. It's almost like the analogy of like, where do you buy a new car, right? There's so many different things out there, and you don't know necessarily what's the best place. A lot of it is word of mouth. A lot of it is, you know, you do your research, and that's where technology is available, and you're doing your Google reviews of different providers. Um, but there are lots of conventions and international consortiums and groups that look at multiple myeloma. There's Facebook groups, and there are, so many of my patients are in Facebook groups, and they talk about the treatment that they are receiving. And you know and a lot of times patients will come to you in your office and say, well, what about this? I heard about this great drug, and it's made and done wonders. So I think being your own advocate, that's important. But then just trying to also to look and see if there is any new or novel research. I think it is a great thing when you see patients being an advocate and saying, hey, are there any clinical trials available where they can actually be involved and make a difference? I mean, all of these drugs that have been approved started off as a clinical trial. All of these started off as a phase 3 study, and that's why we have approval of them.
Hmm. So with that thought of patients bringing information to their doctors, it almost feels like there are two different camps, right? There's the camp of like, don't go on WebMD or Google and look up things, and I think that people sometimes might feel like they're telling their doctor what to do, but then there's also the thin line of saying, hey, like, is this an option for me, or is this a good option? How do doctors typically react, and what should patients expect? Is there a way that they should ask the question or present the information to get the best?
So you're right. It's a slippery slope, right? Because I can fondly remember you going to your patients and they're Googling everything, and some of it is not um, good information, and it's all about, oh, you're taking um, this medication and this is supposed to help cure the disease, or you're going to take all these different supplements and this is supposed to cure the disease. So I think there's good information and there's misinformation, right? And so I am a big proponent of you doing your own research and bringing it to your doctor, and your doctor should be receptive and being understanding for you so that you can learn, right? um, come to your doctor with all of the literature, and so that your doctor should be able to address it. And there's many things that we may not know, but we have the resources, and we also can phone a friend as well, to say, hey, is this patient a good candidate for a clinical trial? What do you think about this? I have called many times, some of my good friends and said, hey, I think a patient might be a good candidate for a clinical trial. Do you have any options for them? So yeah, that never feel like you're afraid or you're being too cumbersome for your physician.
Mm.
It's your job. This is your own body.
And in just thinking from the physician perspective, as you see people in practice, I mean, life is busy. There are lots of patients, there are insurance questions, there are lots of papers being published. It seems that all the time. Um, what, from your perspective, can physicians do to maybe handle those types of suggestions and navigate those conversations with patients better?
It is hard, being a physician, and it's definitely a hard time in the cancer era, for being a physician, because it's just multitudes of information being thrown at you, and numerous conferences that, you're expected to go to, numerous data, numerous game changing, things, and so I think, you just have to be receptive. And if you don't know at that present time, for your provider, it's okay to say, hey, let me get back to you. I think with the time constraints of seeing all of these patients, you can't answer everything in that instance. I mean, that's impossible.
Mhm.
But being able to say, hey, I may not know that information now. Let me phone a friend. Let me get back to you. Let me see what new data there is. And I'll get back to you at your next visit, or I'll give you a phone call. That's okay too.
Mhm. So I want to talk a little bit about supportive care. What are some of the biggest gaps you see in supportive care that need to be addressed, kind of to move forward in survivorship?
So I think, supportive care survivorship is one of the, um, hardest kind of unmet needs when it comes to taking care of patients with cancer. I think we do a great job in discussing, hey, this is the best medication to have sustained MRD. This is the best medication, in terms of overall survival and performance status. But it's hard when we talk about the balance between quality of life and the long-term effects that some of these medications can have on patients. And we're talking about the heart failure that may develop, the significant neuropathy that is, developing, with some of the medications that we're using. That to me is one of the hardest things. One, you win. Hey, it's a cancer win, right? But then you are miserable, in the long term. And so trying to, balance the two. I think a lot of the studies that when we're conducting them, they're doing lots of research on the adverse events and the side effect profile. And the goal is, can we have such a great responding drug, but minimize some of those AEs that develop.
So I'm curious, when a patient does hit this kind of ideal outcome from treatment, what is the typical cadence of follow-up? What should people expect, and what are some of the factors that impact that?
So it really depends on your patient, right? And you have your more compliant patients and your less compliant patients. And that less compliant patient, they're going to see me pretty frequently. So I have a patient that is seeing me definitely once a month, regularly, because I know that they're not following up. They're not even taking their medications. For instance, your Revlimid is oral, and so, many of the patients are able to take those at home, and you can follow them a little bit less frequently. I think with the use of the quadruplet therapies, a lot of them are still being, uh, administered in the office, and so you still get to lay an eye on your patient. So I think it's going to change, but it really depends on the patients. You have to be a little bit more attuned to.
Hmm. Are there any factors like in patients' lives that impact their follow-up ability, and how does that impact their prognosis moving forward? Are people kind of regressing a little bit, or for the most part, are they able to kind of hold steady in this ideal state?
So I think socioeconomics, plays a major part in not just, the overall prognosis, but really how they're adhering and being compliant to the treatment. You always hear of, a husband does better if he has a wife, when it comes to medicine. And I think it's true, because you have some form of a family member, a daughter, a sister, who is making sure that that patient is actually coming to the office and receiving their treatment. Those who are by themselves, who don't really have that support, I think we know, and you don't need the data on that. You know that those patients are not doing as well. You have to make sure that they have access to the care, that they have transportation. I think when we think about just not even being in the city or going to academic centers, many of the academic institutions, you have to drive, and then you have to pay for the parking. It's really difficult for them, for those patients to actually receive the care, and so all those things kind of play a major role in their treatment.
Mm. Um, are we close to a cure for multiple myeloma, and are we close to a cure for multiple myeloma, and what research areas are most promising for the future? Like, what are you looking forward to in 2030?
So I don't, that's hard to say, are we close to a cure? I think we're doing really good when it comes to multiple myeloma. And we look at some of these um, PFS and MRDs of getting up to 90%. I think that's impressive. And um, the thing I'm trying to understand is, when is enough enough? So we started off with triplets, and now we've gone to quadruplets. Like, are we going to be using standard 5 drug therapies? Are we going to be ultimately replacing stem cell transplant as a means of treatment? That's what I want to see in the next 10 years. What is going to be the standard of care? We have so many new drugs that are always replacing the old drugs, and where does that leave the next player?
Hmm. Interesting. So, how do you see clinical trial design and endpoints evolving, particularly with increasing MRD use and new therapy classes?
So, being a provider, we learned that it was always about overall survival, progression-free survival. I think even more progression-free survival than overall survival for me. But this MRD has kind of been a surrogate for your OS and your PFS. And so I think that MRD, particularly in the heme world, the myeloma world, I think that is going to be the way that you're really kind of focusing your trials. Is this really sustained response? Is this surrogate of what is actually happening in that bone marrow? So I think for sure, I think MRD is going to be kind of the new wave and the way to go for years to come.
Hmm. And looking forward to things like clinical trial design, what do you think are some of the things that we can do to get more widespread participation in clinical trials as we move forward in research?
I think one, it's you have to have more representation, and it's not just representation in the patient level, but I think it's representation in the provider level too. And I think for me, my goal is definitely to try to get more participation, especially in minorities where you don't see much participation. Um, I think you just really have to have that community, that communication, that trust with your patient. And many patients, they listen to their doctors, and so as long as you have that trust and you can be that voice, I think you should start to get more engagement.
Hmm. What are the biggest practical or ethical barriers to making state-of-the-art myeloma treatment globally accessible for all patients?
Um, I would say access to care and affordability. The access is hard. I think it's very hard, especially out in the community where we don't realize some of the barriers that are existing. It's not just just the financial barriers. It's the mental capacity. We are in a I think in this time that we're living in is very very stressful. Um, and really looking at all of the implications that it has had, not just on the patients, but even on the financial institutions, the hospitals. People are losing their 304B statuses and not being able to take care and provide for these patients.
You know, last question, with all of the new advancements and all of the new research coming out, How are doctors keeping up with all of this? And what is that process like of deciding if you're going to try a new regimen or if you're going to incorporate something into your, standard approach to treatment or even diagnosis?
So it is hard. It is hard trying to keep up with the new data, and I think that's where specialists come into play too. And so, as a specialist, you're really keen on just learning this one specific topic. Um, but there is lots of different groups. So going to ASH is American Society of Hematology, or your ASCO event, and you're learning about the newest data. Having your resources as far as talking to your colleagues, talking to pharmaceutical companies. I think people are still shying away from seeing a pharmaceutical rep, but they're a lot of times the first step to actually learning about a new medication. And so I am still a big proponent of learning and not being afraid to talk to the reps about new drugs and learning about what's the next step. And so if you don't know anything about it, that's the only way to really learn about things. I think in the private practice world, you're still very limited on how much time that you have to take care of patients, and so you don't have time to read or look at new literature or look at your new journals, and so just making sure that you have different opportunities to learn.
Hmm. Well, this has been an amazing conversation, Dr. Rozell. Thank you so much for joining
Thank
us
you.
on MD Newsline.